Okay, hi everyone. I'm Joe Weiner, and I'm joined by my colleagues Taranjit Ahuja and Janice John, and we're really delighted to be here today to share our thoughts with you about the importance of communication and physical exam skills. So we're all from the Zucker School of Medicine at Hofstra Northwell. I'm a psychiatrist. Dr. Ahuja is a pediatrician, as is Dr. John. So let's start talking about communication.
Dr. Weiner, can you just mute your, it's transcribing what you're
That
saying?
thing? Well, let's see if I can, because life is very unpredictable, isn't it? Let's see. Can I do that? How do I do that? Oh, there's some button here. I think I remember. There we
There
go.
we go.
I knew it all along. So much of life, guys, is about dealing with the unpredictable. So let's start talking about communication. And all right. So you guys are pretty good at using electronics. So type in the chat box, and perhaps, Dr. Ahuja, could you read some thoughts from the audience, because I can't actually see the chat box here.
Yes, I can.
The number one reason why we went into medicine, or for those of you who are planning to go into medicine or hoping to go into medicine, the number one reason why is, so
I'm seeing gratification, to make a difference in the field, to serve those who need, to serve people, to connect with people, to help people, serving others, relieve suffering, help people, provide comfort.
Yeah, I think it's variations on a theme, huh? And when we've given talks, Grand Rounds, by far the number one answer is what you guys have said, variations of, to help people. So we're all aligned here. So if we went into medicine, or we're planning to go into medicine to help people, it means we're good people, right? And if we're good people, why do we need to learn communication? Because we're all kind and we care. And so let's think about this. And the reason why we need to learn specific communication skills, healthcare communication skills, are as follows: that healthcare often involves pretty complicated situations, difficult conversations. Oops, let's go back up one. And stressful situations that make communication particularly challenging. And you see this play out in the news, and you see this play out in TV shows, the tensions and complexities that exist in challenging medical situations. Let's see. Okay. And so when we think about what healthcare communication requires under those circumstances, it requires highly specialized knowledge about interpersonal communication. It's more than just being a nice person. And it requires specific self-reflective skills over time that enable you to grow through young adulthood, mid-career, and late career, because we're constantly faced with challenges that we have not encountered before, that requires personal growth and self-reflection. And in addition, like any other skill, playing a musical instrument, playing a sport, healthcare communication requires deliberate practice with coaching. And so given all of that, let's ask the following question: what makes a doctor a good doctor? So years ago, and you're going to see a younger version of me in this video tape, slightly more hair, slightly less gray. I went into North Shore Hospital, actually it was Long Island Jewish Medical Center, with a video camera with informed consent from the people that I interviewed. And I asked them, what makes a doctor a good doctor? These are patients and family members. Let's see what they had to say.
Hi, my name is Dr. Joe Weiner. Today you're going to be watching a videotape that asks the question, what makes a doctor a good doctor? During my career, I've had the opportunity to ask that question of hundreds of patients and family members. In this videotape, you're going to be seeing men, women, younger patients, older patients, patients of different races. Some of the patients that you're going to be seeing in this videotape have very serious medical illnesses, yet their answers share some common denominators. So while you're watching this videotape, you may want to ponder from the patient's and the family's perspective, what makes a doctor a good doctor? What do you think makes a doctor a good doctor?
They listen. So we came into the hospital a week ago, Monday, so it's like 10 days now, to find out that Liam has, it's called popliteal entrapment. It's a muscle entrapment of that artery. He never rushed us. He never looked at his watch.
A doctor that listens to the patient and try to understand and realize that only the patient knows what's normal with their body.
When he or she listens.
Okay.
He was always in the moment with us, you know.
Certain ones that approach you and ask you, what do you need? What do you think will help you? You know, like I know you've been going through this for over a decade. So apparently you know what helps just as good as I do.
So you felt that that doctor wasn't, you were given a lot
Listening.
listening. You felt the doctor wasn't listening?
I don't think he was listening.
Actually sitting there, taking their time to hear my feelings, my thoughts, and not treat me as like just something on a conveyor belt.
Speaking for myself, yeah, I want to feel like I'm just not another number.
Mm-hmm.
You want that doctor to be invested.
I believe a doctor is a good doctor that actually cares.
I'm looking for people to be caring at first.
To get a really good idea of what's going on with the patient.
It's usually, you know, more about what's going on with you in the whole. You know, it's like, what's hurting? What's going on? Is this normal? Is this abnormal? You know, I'm going to check into your prior records from you being here.
And they really take an interest in my health.
But it seems like those doctors that are more in tune with a patient's needs and more in tune with a patient's background.
By giving me the proper care, taking care of me with the proper medications, that I can see that there's good results.
That's what you want, a proactive doctor.
You have to communicate with the patient, you know.
He has to be an effective communicator.
Had Liam part of that decision-making process?
Well, they must want to help people. He has to like his job. So if you're not dedicated to be a doctor, you're not going to be a good doctor.
Bedside manner and understanding are just as great as clinical knowledge.
He spoke to Liam with such respect.
The ability to listen, I guess it's the same thing that makes you a good person. You could be in a marriage for 30 years and never listen to each other and never be there. So to break down the barrier and actually listen and respond to the needs of that person, and then to be able to communicate back to that person would be the basis of a good doctor.
It's powerful stuff. You notice that they didn't say a doctor that knows all of clinical science. Well, it's implied and expected that you're capable scientifically. The question is, what makes a doctor a good doctor? And that's what they were thinking about. Dr.
All right.
Ahuja?
Thank you, Dr. Weiner. So I want to ask you all, what do you do when you need to find a good doctor? What do you all do? Enter it into the chat box. Research, Google, ask others, look at reviews, read reviews, ask friends. So basically, you want a reference. You want either a reference from somebody you trust in your inner circle, whether that be friends or family, or online reviews. Dr. Weiner, if you could press enter.
Drum roll.
Drum roll.
Okay. There
That's
you go.
exactly right. That's where I was going. You search for online reviews. Just like
Do you have
any other.
examples of that?
I'm sorry?
Do you have any examples of
I
online?
do. But before I go there, I just wanted to add that it's like any other service. You want to make sure the person you're trusting with your health is somebody that, has been rated well by others, whether, again, that's your inner circle or online reviews, as we would look for reviews for any other service that we need. All right, if we can press enter now.
Okay, let's see what Dr. Ahuja found.
So these are actual reviews online about some physicians that Dr. Weiner and I considered were poor reviews. So Dr. Blank was not able to answer many of my questions. It didn't seem like he was really listening to what I was explaining. Next, this is another individual, uninterested, distracted. I know she sees these disorders every day and it must get boring to her, but couldn't she at least pretend to care? Ouch. Okay, so here are some examples of good reviews. On the next slide, please. So Dr. Blank is very caring and listens well, also has a very sharp mind, able to diagnose well and help clarify any confusion you may have. Best there is. There's one more. Dr. Blank is an excellent doctor. She listens to you and spends the needed time to help you, and she really cares. She will also take the time to call you to make sure you're doing well. I wish all doctors were like her. Next slide. So I want you to enter into the chat box. Did you all notice a recurring theme? What did you notice about those doctors? Listening, communication skills, empathy, caring, listening. Exactly where I want to go. So the point of this was you can be the smartest individual in the classroom, but if you're lacking the communication skills, that is what will be noticeable to your patients, and that's what they're going to take away. You may have done everything right, or the right treatment, the right, sort of management plan, but if they didn't feel like you listened, they didn't feel that you empathized, that's all they're going to remember. So our purpose of this is to illustrate that communication skills are highly important, as are clinical skills. Thank you. Next slide, please.
So then the question becomes, how do you listen to a patient? We understand listening is really important. So we'd like to give you a very, 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 very brief overview of something called the three-function model of medical dialogue. And you're getting a heads up of the 4th edition of this three-function model, which won't come out till 2023. And this is based on a chapter that I wrote with Stephen Cole. And this is a refinement of previous editions of this three-function model. And what the model says is that there are 3 and only 3 functions of a medical dialogue. And the prior editions talked about different kinds of functions, but we kind of refined it in the 4th edition. So the 3 functions are connect, co-construct, and collaborate. I'll very briefly explain what this means. The first function, connect, it goes 2 ways. Older ways of thinking about the patient-doctor relationship is that the doctor would establish trust with the patient. The doctor would do something to the patient to kind of make the patient trust them. And what we think about it now is it's really a 2-way street. The doctor has to connect, the patient has to connect. If there are major lacks of connection, things don't go as well. And there's a lot of medical literature to support that. Patient doesn't offer as much to the doctor, patient doesn't trust the doctor as much, patient doesn't necessarily believe the diagnosis or follow the treatment plan as much. The second function is something called co-construct, and this is pretty complicated, but I'll distill it down to, and by the way, if you want to understand this in greater detail, study really, really hard, do very, very well, apply to Hofstra Medical School, and we'll teach it all to you. So co-construct, and what co-construct means is that the doctor and the patient author together the history. If you watch a show like House, like in House, the doctor asks, the patient answers, the patient's very dutiful, they do whatever the doctor says, and the doctor, through sheer active intellect, decides what the diagnosis is and comes up with the treatment. But that's very superficial. It's really, again, a 2-way street where the doctor and the patient dialogue, and together they figure out what's going on. Again, that's a very brief description of this. Function 3 is collaboration. It's not prescribing, it's not diagnosing, it's collaborating, because with without the presence rather of collaboration, people are not going to cooperate as well, and they won't tolerate treatments with side effects. Unless they believe you, unless they trust you, unless they think you're traveling by their side, they're just not going to go through the journey as easily with you. Let's go to the next slide. Wow, a demonstration. How are we going to do this, Dr. Ahuja?
I think we're going to show them what we're talking about. So application is as important as understanding what we're talking about. So
okay, and is everyone's videos turned off? Do you
yes,
think?
it is. Yeah. So
All
if
right,
you
just checking.
yeah, so if you actually stop sharing your slides, we'll come up on the screen. There we go.
All right, that looks good, right?
That looks good.
So, are you going to be a patient, Dr. Ahuja?
I will.
What's your name?
So my name's Taranjita Ahuja.
And what's your date of birth?
My date of birth is 1/1/54.
And what's the story? What's going on with you so everybody knows what this demonstration's about?
Sure. So I am a patient and I am calling Dr. Weiner. He is not my regular physician. My regular physician is Dr. Smith. And I have, in my role play, I have been diagnosed with COVID about 8 days ago. And today I'm feeling a bit worse and I'm a bit concerned. So I wanted to talk to my doctor who wasn't available. Dr. Weiner and I are meeting for the first time through an online interface so he could interview and do parts of the physical by Dr. John.
So this is one of these virtual visits that occur over the computer, in other words, because of what's going on with COVID. Is that correct?
That's exactly right.
All right. And let's start. So I get a notification you're in my virtual waiting room. Oh, there's a question. Can I see, and I'm going to call you Mrs. Ahuja for this role play. You're not a doctor in this role play, is that correct?
Yes, please. Or you can make up another name if you wanted.
No, that's because my memory is being challenged as it is. So you have a question, can I see Mrs. Ahuja's medical records? And the answer is yes, because it's, we're sharing, I'm a covering doctor for the medical practice that Mrs. Ahuja goes to. Okay, so I see you in my waiting room and I am going to let you in and now you appear. Hi, Mrs. Ahuja.
Hi.
Hi, I'm Dr. Joseph Weiner. Your doctor, Dr. Smith, is not in today. He's on vacation. I'm covering his practice. And I understand that you wanted to see us in an urgent visit today. So I'd like to find out what's going on and how we can help you. Before we do that, I just want to confirm a couple of things because this is a new way of us meeting with each other through the computer. Would that be okay if I confirm a couple of things?
Yes, of course.
Thank you. I appreciate your patience because I know you're not feeling well. First of all, can you tell me your full name and your date of birth so I am making sure I'm speaking to the correct person?
Sure, it's Taranjita Ahuja 1/1/54.
Okay. And so you are the correct person. Do you have privacy to speak with me?
Yeah, I'm alone.
Okay. And can you hear me okay?
Yes, I can.
All right. And how do you like to best be called?
Taranjit's fine.
Taranjeet. Okay, Taranjeet. So I understand you're concerned and you want to have an emergency visit over the computer. Tell me what's going on.
So Doc, I got diagnosed with COVID about 8 days ago in an urgent care. And, they said just to keep up with the Tylenol for fever and take Robitussin for cough. And I've just been feeling a little short of breath now.
I see. It looks, just looking at your face, you look a little worried about that.
I am.
Yeah. I'm going to want to hear about your worries in a moment and hear more about your shortness of breath, just to make sure we cover everything we need to. In addition to talking about the shortness of breath, what else do you want to make sure we discuss?
That's it, Doc. I just want to see what I should do.
Okay. What I'd like you to do then is tell me the story about the shortness of breath over the last couple of days, because I know Dr. Smith saw you 8 days, or you were seen in the emergency room about 8 days ago. So since then, the last few days, tell me the story about the shortness of breath, starting from when you really started not to feel well until now.
Sure, Doc. So, as I said, I got diagnosed with COVID about a little over a week ago, 8 days ago. I, work at a local hospital in the cafeteria, and, I started having a fever and cough. And so based, just because of my exposure, I ended up going to the urgent care, and that's where they tested me positive. As I said, they had told me to take Tylenol and Robitussin and just, quarantine at home. They also told me to download an app where I can check my oxygen level, and I've been checking, and usually it's around 96, and I think they said that that's normal, but now I see it lower, so it's around like 94ish, 95, and I'm still having fevers. Although not as high. Initially my fever was like 101.5, and now it's between 100.4 to 100.9. But what was really concerning to me was, when in the last sort of day or so, I just feel like I can't catch my breath. I climbed up the front steps this morning to get my paper and felt a bit dizzy, and, I'm feeling a little chest tightness and heaviness with my breathing and talking. So I felt concerned, and I wanted to see what I should do.
Well, first of all, thank you so much for contacting us today. I'm really glad you did. We're going to get to the bottom of this and see how we can be of best help to you. I want to make sure that I heard your story correctly. About 8 days ago, you were diagnosed with COVID, and you were hanging in there with Tylenol. Your fevers never went away, but you were sort of hanging in there. They may have even reduced a little bit. And about a couple of days ago, it was that you noticed that your breathing was a little bit heavier. And it got so bad that it was hard for you to even climb up a flight of stairs. Is that correct?
Roundabout, right.
About a flight of stairs. And what really concerned you is you were checking your oxygen level, and it was 96 until recently, very recently, the last day or so, and it went down to 94, 95. Is that correct?
That's correct.
Yeah. About all this that's going on right now, I'd like to understand what worries you the most.
Doc, I'm nervous to go to the ER. I have a feeling if I go, I'm never going to come back.
That's very scary. So you're going to want to know from us whether you should go to the emergency room or not, just to begin with, or can you ride this out at home?
It is scary, and I appreciate you saying that, because it is scary.
Yeah, and we're going to figure out whether you need to go to the emergency room or not. Would that be okay?
That's reassuring.
Okay. So let's stop the role play there. And if you guys have questions about any of this, put them in the chat box. We're going to address them at the end of the talk, and we're going to turn this over to Dr. John now.
Dr. Weiner, do you want to put it in screen share mode?
Oh, can you see my slides?
Oh, we can. I didn't know if you wanted to put it in screen share. Like slideshow?
Oh, okay. Sorry. Is it in slideshow mode now?
No.
No.
Just hit slideshow up top.
It's okay.
Okay.
All right. We'll just go through. Okay. So actually, I think I do need to put it in. Let me stop the share. I'm sorry, guys. One more chance. Let me see. Is it in presentation mode?
Not yet.
Okay. That's all right. If Joshua, if you're here and you can help, I would appreciate it. But if not, we'll just go ahead. So you just witnessed a role play of Dr. Weiner interviewing Dr. Ahuja, who is playing the role of Taranjit Ahuja, our patient. And in reality, what would happen when you have an interaction with a patient is you first want to connect using your communication skills, right? And establish rapport so that you can really be able to understand your patient's story and understand who they are, the journey that they've been going through, what they've been experiencing. You're going to apply some of your clinical reasoning and be able to ask specific questions so you can test your hypotheses of what you think is going on. And then we're going to continue connection with a physical exam. And so we're going to connect. And I'm going to ask you, so this would be good if I could put this in slideshow. Let me see.
Dr. John, if you see, yeah.
From current slide, let's see.
Yeah.
Is it in slideshow mode now?
Not sure why, but it's still not showing up in slideshow mode.
Okay. I'm going to try one more thing because I don't want to give answers away. Let me try this also. Now, are you guys seeing, let's talk about physical exam in slideshow mode? Okay.
That works, yes.
All right. Okay, so what is the physical exam? And I'm going to be looking at the chat. Yay, yay, thanks for cheering. Okay, so what is the physical exam? Anyone have any answers? Examining the patient through touch and feel. That's great. I love that. Any other? Observation and palpation. I like that. Thoroughly screening the patient. The evaluation of the patient's physical health. Auscultation. Really good keywords in there. Okay, so the way I like to describe it is when health professionals utilize specific techniques, maneuvers, or measurements to gain information about a patient's body so that we can learn about their health. And so just like you guys wrote in the chat, I like to say we use our senses. We look, we listen, we feel. And in medical terms, that would be observe or inspect. We auscultate, that's to listen, and to palpate, which is to feel. And many of you already put that in the chat. We use this information so that we can test our hypotheses and make diagnoses. And so many of you have heard of the head to toe or complete physical exam versus what you're more often experiencing, which is the focused physical exam or problem-based physical exam, and what we like to call at Zucker School of Medicine, the hypothesis-driven physical exam. And we can talk about that a little bit. But first, parts of the physical exam. Anyone want to put into the chat some of the components of the physical exam? And this is great, inspection, palpation, percussion, auscultation. Okay, vitals, height, BP temp, check for reflexes, lung, heart sounds, HENT general, excellent. BMI, temperature, checking ears, weight, blood pressure, lymph nodes, excellent. Okay, great, really, really good answers. And so we teach our medical students in their first 7 weeks of school the head to toe physical exam, which incorporates most of this. We don't do the breast, pelvic, and GU exams in the first 7 weeks, but we teach our students kind of in a systematic way, starting with general appearance. And we're going to delve into general appearance a little bit more at the very end. And then we do vital signs. Anyone want to holler what the 4 vital signs are in the chat? Odor is important too. That was good. Oh, Dr. Ahuja put that in there. Yes. Let me speak to Dr. Ahuja's point. When I was writing out, like you look, you listen, you feel, and you're talking about your senses. And I was going to say we also smell. You can get a lot of information, health information about from smells. And back in the day, they used to even use taste. So we don't do that so much these days. But so I see blood pressure, temperature, heart rate, and respiratory rate, which is great. Those are our 4 main vital signs, and we would all agree that the 5th vital sign would be pain. And then pulse oximetry, which is someone's oxygen saturation, may be considered a vital sign as well. So these are all of the components of the physical exam. And before we kind of even talk about, we're going to delve a little bit deeper into the general appearance today, but there are a few things that are key to any part of the physical exam. And way before coronavirus, way before this pandemic, hand hygiene has always been a really important part of the physical exam. And so that means we're washing our hands before we touch a patient, and we're washing our hands after we examine a patient. And now I would add, now with the pandemic, the use of PPE, personal protective equipment, including your mask, a face shield or goggles. We've been using these goggles, but face shields, gloves, sometimes even a gown those are important things to consider as well in a pandemic. Very important to consider is your patient's comfort and modesty. So you really are partnering with your patient. You want to empower your patient. We don't know where our patients have been, what their experiences in life have been, if they've experienced physical or sexual trauma, if they have experienced trauma because they're part of the military, or really what their life experiences have been. So we really want to be very mindful and sensitive to our patient's comfort, and also to their modesty. So we also want to make sure anytime we're examining a patient that if there's a part of the body that does not need to be exposed, that we're using a gown or to be able to cover up areas of the body that are not being examined. And then really important, actually Dr. Ahuja brought this up in one of our faculty meetings. Now we're examining patients like this. So we don't get to see patients' facial expressions. Now more than ever, our communication skills are really important. We want to make sure our patient knows what we're doing, why we're doing it. Obviously not using jargon, using lay terminology, but communicating with your patient so that they're in the loop. I really like it when we teach our students, we really like our medical students to be able to share findings as well. So you take a blood pressure, you tell them what it is. It may not be very meaningful to your patient, so you might say, it's pretty healthy, it's in a healthy range. So you give a little bit of an interpretation. And then finally, you really, as you practice and you become more familiar, your flow is important, because just like you can speak with confidence, and it inspires confidence in your patients, you can also do a physical exam with confidence. And when you do that, there's a flow, and that does inspire confidence in your patients as well. So those are some key considerations no matter what part of the physical exam you're doing. Oh, sorry. Okay, so those are those key considerations. General appearance. Okay, now we'll get back to the chat box. So when we're talking about general appearance, first I'm going to ask you, when does the physical exam start? Okay, I'll answer that question at the end. When you first see the patient, exactly. As soon as your eyes lay on a patient, like as they're walking into the room, as you start to talk to them, they may be already seated at the table or on a chair. As you enter the room, the physical exam has already begun, because you're already gathering information from your observations, right? And so what kinds of information can we collect about a patient's health from just observation? And we consider that the general appearance part of the physical exam. Great. Color, whether they're pale, jaundiced, posture, mood. So we can get a sense of their mood from their affect, what we can see visually. Obvious, someone said contusions or lacerations, so obvious trauma. Rashes on the skin, if they're pale or flushed, their posture, their weight or body habitus. Odor, absolutely. Fatigue, hair, nervousness. These are labored breathing. I love that. Agitated. All of these are excellent answers. And here are some things that I popped in. I think we covered all of this, and all of this can give us information about patients' health. Now, I want to, if you don't listen to anything else, this is important to listen to. General appearance is really important, and probably one of the most critical pieces of the physical exam, and we can even do this via telemedicine, right? So this is a really adaptable skill, but it's really important that we're mindful that we don't make assumptions. We can make observations, and those observations are a starting point for us to do some continued exploration, right? We can get some information, but we need to make sure we verify and we don't make assumptions. So there's a lot of cognitive biases that can get in the way. So we're not just seeing something and making assumptions, but we're seeing something, making some observations, and then exploring those, okay? So that's a key point here. So let's think about your patient, Mrs. Ahuja, the one in the role play. What were your hypotheses about what was going on with her? So she was diagnosed with, from the story she was sharing with Dr. Weiner, she had been diagnosed with COVID-19 about 8 days ago. Now she's experiencing some shortness of breath that she had not experienced before. What might be going on? Lung damage due to COVID, right? Okay. Maybe a pulmonary embolism. We don't expect that. You'll know all of the potential things, but respiratory complications. It could be a pneumonia, secondary pneumonia. Anxiety. I love that, Sonia, that you're thinking about that. Surely, you know, with everything that's going on, this could certainly not even be related to her lungs. It could be completely related to anxiety, that she's having shortness of breath. I would ask if she had any other symptoms, about fever again, how the temperature is. I like that. Underlying asthma. That's a great point. Does she have any comorbid conditions? What's her medical history? Those are all excellent things that I love your contributions in the chat. So those are great hypotheses. So you made some hypotheses, and now what we're going to do, I mean, and what you would probably do in real life is you would explore those hypotheses. You might ask her, what is your past medical history? Do you have a diagnosis of asthma? You know, you might ask about your fever. How have your fevers been? And I think that there was some conversation about that. You might ask if she's been coughing up any phlegm, or if she's been coughing up blood. Those might give us some information, right? So you'd further test your hypotheses with your history when you're communicating with your patient in that conversation. But then you can also do some parts of the physical exam. So now, what parts of the physical exam would you want to do for Mrs. Ahuja, Dr. Mrs. Ahuja? Listening to the sound of breathing and chest. Okay, wait, pause before you guys put anything else in the chat. What's the first thing you do? The very first part of your physical exam that we just talked about. Connect, consent, ask for consent. Yep. Now you guys are wash hands. I love that. Say hi. All of that is good. PPE. You guys are good. You guys, very good. Greet your patient. General appearance. That's really what I was trying to get at, right? So hopefully you already have your PPE on, but if not, I think all of the other answers were great. Washing your hands, establishing rapport, all of that happens in that communication piece when you're gathering your history and collaborating with your patient, you're co-constructing, right? But you want to, your first part, when I ask what parts of the physical exam would you like to do, the first part would be general appearance. Then vital signs would be good. And then I saw someone put into the chat to do a thorough pulmonary exam, which would be great, right? We would look and listen, maybe even percuss and palpate the chest and the lungs, right? And we're not going to go into those details, but what else would you, what else might you do? Let's please clarify if this is still a remote visit. No, we can say we're in person. Oxygen saturation, absolutely. You can do a pulse ox. She did say she had a O2 sat, so if it was remote, we could get that. Lab reports are part, not necessarily, it is objective data, not necessarily part of the physical exam, but it's a good thought. Pulse ox, prior history is part of the communication. We're talking about the parts of the physical exam we like to do. Check a temperature, okay, so that's part of vital signs, absolutely. Listen to her lungs. Mental health exam, okay. Yeah, maybe if we were concerned, especially if we had anxiety in the differential, we might just ask her about her mood and how she's been doing. Touch for pain along the chest cavity, for sure. if we thought there was maybe a mass or something like that. Breathing rate, that's called your respiratory rate, which is part of your vital signs. A cranial nerve check, if we were concerned. Okay, good. I think doing a good cardiovascular exam would be good. And doing a good head, eyes, ears, nose, and throat exam, potentially, if she had any upper respiratory symptoms, which I don't think she did. But definitely a thorough pulmonary and thorough cardiovascular exam. I would also probably do a good skin exam because of the skin manifestations of COVID-19. But what I'd like for you to know is that this is all part of a focused physical exam. We don't necessarily have to do the nitty-gritty from head to toe every time. Although if we're concerned and we're looking for answers and we don't, we can certainly be more thorough, err on the side of being more thorough. Okay. Does anyone know who these folks are in the slides? I always like to know and give special props to my basketball fans. Tim Duncan, and thank you. Okay, so Popovich is one of my favorite coaches in the NBA because he is a very humble coach. But I put this picture up here. Now Tim Duncan is assistant coach of the Spurs, but I put this picture here because I want to drive home the idea that communication and physical examination and clinical reasoning, which we're not talking about today, are all skills. They're clinical skills. And just like playing the violin or playing a sport, these skills cannot be mastered unless you practice and deliberately practice. Okay, you can't read about it, study and read and just get good at these things. These are skills that need to be practiced. And so so this concept of deliberate practice, which Dr. Weiner alluded to in his slides as well, and he also alluded to the idea of a coach, is really important. And I'd love for you guys to learn this concept now as you're earlier in your journey, in your professional journey. Let me just say that the way I like to describe this concept of deliberate practice is, say that I go jogging every day, every morning, and I jog a mile every morning, and then I take a shower, and then I eat breakfast, and I start my day, and I can check. I did my mile run. I may never get better in that whole month, and in a year, I may never get better, but I did it. I went through the motions. Check. It's off my list of things to do. That may not, just practicing like that may not actually help you to improve, but if after I run, I reflect and think, what could I have done better? What did I do really effectively? Where can I improve? Or if what would be super ideal is if I had a coach, someone who's an expert who could observe and watch me and share from their expertise, from their experience and expertise, be able to say, hey, listen, you could work on your stride length a little bit. You could really maximize your stride length, and then you'd be a little bit more effective with that mile run. So if I can do that self-reflection and have a coach be able to give me some specific feedback, then I can do that mile run every day, and I can be mindful of specifically my stride length for a week and see how that helps me improve my time, or make me not as exhausted at the end of it. Or maybe I can work on my breathing, and maybe that I can focus my attention on my breathing for a couple of weeks and see how that helps me to improve my running. So ultimately, deliberate practice is focused practice with the intention to improve. Okay, and so I say all this because we're talking about our communication and physical exam skills, and it's really important that the clinical skills you'll be learning in your journey, that you really take every opportunity to practice and to get feedback and to reflect. Okay, so we're going to do a little exercise. We're going to end with this exercise here. And it sounds like some of you have some clinical experience, some of you have more or less, but let's try this. I'm a pediatrician, as Dr. Weiner mentioned. So you're going to see a series of pictures. I'm going to look at the chat box. I want you to tell me, based on general appearance, What are some observations you're making that could give us some information about this patient's health? Pop it into the chat box. Happy. Happy patient, smiling, energetic. So yeah, clearly not like dehydrated or in any kind of distress. Definitely well fed. Nice little baby rolls there. No distress, responsive, playing with toys. Very nice observation. You see in his hand, he's got a toy. He might even roll that motorcycle on the exam counter, and that might tell me something about his gross and fine motor skills, right? So there's a lot of information I can get about this patient's development just from general appearance. Let's go to the next picture. What do we see here? Jaundice. Right, the yellow eyes, the sclera, the whites of this patient's eyes, which should be white, are actually quite yellow. And that could give us some information about his liver, about his gallbladder, and about the biliary tract. I also noticed that he happens to have sort of a little bit of a unibrow, which could be related to a genetic syndrome, or it could just be irrelevant to his health. Okay, let's see this. What about this third baby? Rash, crying, red spots, rashes, irritation, distress. They look distressed, maybe in pain. Yeah, this little baby boy he does not look happy. He is ill appearing, right? We see the rash, red eyes, yes. So you see that there's some redness to his eyes. And if I told you there was no goop coming out of his eyes, no purulent discharge, we could maybe say that this patient had non-purulent conjunctivitis. We see, what about his lips? Anyone make any observations about his red eyes, flared nose, dry, very good. Something chapped, very good. You see that he's got some peeling skin to his lips. This patient actually has a condition called Kawasaki disease, which happens to be a pediatric complication of coronavirus. And he is definitely very sick. These children tend to look and be very sick. How about this fourth kid? Smiling, happy. Great. Prior surgery. Somebody wrote that. What makes you think prior surgery? He had some sort of surgery. Cardiac. Scar on chest. Very good. Okay, so this fourth kid, he's got a sternal scar. It's making me think as a pediatrician, because of his age, that if he's had some sort of open heart surgery, he may have had, though we would have to confirm this, a congenital heart disease that required open heart surgery. So that's telling me something. What about his environment? What can we, yeah, it could be a VSD, one of the most common congenital heart diseases. What can we tell about his environment? He's in the hospital. Yes, he's got a hospital robe on. His background, we see all the wires. Okay. He's comfortable in the hospital setting. That's true. He seems not afraid. He seems like maybe he's been there for a while, or he's been there a few times. He's got some cardiac monitoring, right? His hand is clenched. Somebody wrote that. That's a really interesting observation, because I have a colleague who's a hand surgeon who made the same observation about his hands. And he actually said that the resting hand position that this patient is in may be indicative of a neurologic injury, potentially intraoperatively at some point. We don't know for sure, but it's something worth exploring. Okay, let's go to the next picture. How about this fifth guy with the doctor embracing him? Crying. Definitely he's crying. He seems like he's in pain, or he's scared, uncomfortable. He has a cast. Good. Okay. So we see in this picture that there is a splint or cast of some sort on his left upper extremity. We're not really sure what the injury is, but he definitely has some sort of injury. Good. Let's go to the next one. How about this picture of this young girl? Hair loss. That's the most obvious thing, as we can see some long strands in some areas of complete alopecia. She's had a surgery. We're not sure if she's had a surgery, but she does have a central line in, so she's at least had a procedure. That's what. So that tube that looks like it's an IV that's going straight into her neck is what's called a central line. Use that when you're infusing medications. Okay, what else? She's holding a syringe. She's got dark circles around her eyes. Yeah, they're a little sunken in. So it may be someone said she's holding a teddy bear. It may be that she's been in the hospital for a while. The alopecia and the central line make me think potentially she is getting chemotherapy and as a side effect lost some hair. It's possible. We're not sure, but we can definitely explore those things. Let's see this next picture. What do we see here? Skinny. Yeah, we might even call him cachectic. You know, you see his ribs, his bones are kind of sticking out, right? What else? Yep, what else? But able to do activities like painting, yes. He looks like he might be in a child life room in a hospital. Why do I think he's in a hospital? Patch on. Okay, good. He's got a hospital band. He's also got an IV. Ooh, he's got an IV pole right next to him. Somebody said he had a patch on his belly. Maybe, possibly, I'm just thinking, I don't know for sure, that maybe he's getting nutrition through a G-tube, and so there's a patch right over his belly button. It's possible. But, you know, these are things that you have to appreciate. You look at the environment, there's someone near him. Maybe it's a volunteer, maybe it's a family member. Okay, let's go to this last picture. What do we see in this picture? What kind of, somebody wrote, okay, what do you see about this last picture? Genetic condition, right. Trisomy 21, that was also known as Down syndrome. So this patient has facial features of this syndrome, which can give us some information about her health. It can give us some information about her growth trajectory, and it could give us some information potentially about something she might be at increased risk for. But she also looks like she's really engaged in some sort of activity here. So all of that to say that the physical exam is really important. It's an extension of connection, right? And there's a lot of things from general appearance that we can observe, but that's a starting point for us to be able to explore. I like to say that we can connect and serve our patients with our clinical skills. We may not be in a position where we have every laboratory test available to us, every imaging or diagnostic test available, but we have ourselves. We have our communication skills. We have our humanity, right? We have our critical thinking skills, which when we're applying that to clinical scenarios, we call that our clinical reasoning, thinking through what could possibly be going on and thinking outside the box, right? And then testing our hypotheses with questions, but then further testing our hypotheses with an intentional physical exam, right? And not just going through the motions, but connecting and being very intentional with gathering information while we're doing the physical exam, which I think is a beautiful, when you talk about the art of medicine, I think of the physical exam. And so I'll leave you with this. If you look at the physical exam, one individual coming to another, telling them things they would not tell their spouse or a rabbi or priest, and then incredibly disrobing and allowing touch. I think our skills in examining a patient have to be worthy of that kind of trust. And so I'll leave you with that. And we've tried to address as many of the comments as possible and questions. But if anyone, we have about 2 or 3 minutes that we can address any other questions. How do you respond to a patient who demands to only be examined? I'll stop the screen share. Who demands to be, oh, I lost it. Demands to be examined by a certain race or gender. I think that's great. We call that those, it can be overt discrimination by a patient to a provider, or it could come in the form of a microaggression. And we teach our students and we practice ways of addressing that. And, you know, the patients we see and serve are diverse. And recognizing that we have our job and our responsibility is first to take care of our patient. If for some reason we feel like we cannot, because of the patient's desires or because we are affected by their comments, then if we think it's going to serve the patient better to be seen by someone else, a partner or someone else on the team, we will. But if that's not an option, then we put those things aside and we do the best we can to be professional.
There's one question about building trust with pediatric patients, if I can answer.
Sure.
So that's a great question. How do you build trust with children? So, you know, we see from the span of 0, you know, all the way up to 21. And so the way you build trust is really tuned into their developmental age. And if it's a younger child, I'll often, before COVID, walk in with a little trinket on my stethoscope that makes sounds, or stickers. And if it's an older adolescent, you know, noticing from, you know, their clothing or hat, they're wearing a special logo from a basketball team and saying, oh, did you watch that game last night? And really connecting with the patient on their level is a way to build trust, and acknowledging them. And the older they get, the more autonomy they want in their care. So it's important to realize that you talk to the patient as they get older rather than the parent.
Okay, there's a lot of questions. If you're on a telehealth video.
Karen, I mean, Janice, may I double back, because we only have a few seconds left, to the question about gender or race. I would also say, well, what have your experiences been? I would try to understand the patient's point of view. And sometimes patients think that you won't give them good care because of prior experiences. So it gets back to the idea of connection and understanding with empathy the patient's point of view. And oftentimes that dialogue is enough to turn things in a better direction.
And trust, yeah. I think we're at time, but I'm going to put in the chat my email address. Let me see if I can. And if you guys ever want to reach out, feel free. Oops. Did it go there? Yep. Okay. All right. Thanks. Thank you all. And thank you, Joshua, for coordinating this.
Joshua.
Yep. Thank you guys for joining us today. It was great.
Thank you.
Thank you, everyone. Good luck.
Good luck.
Take care.
Bye.
Okay, bye.
Bye.